lung cancer in the left lower lobe. The type of cancer is non-small cell cancer. The patients were placed in lateral decubitus position. First, we identify and note anatomic landmarks on the right thorax. Working port made on the 8th intercostal space, along the anterior axillary line and posterior axillary line. For the two-port approach, 3.5 centimeters working port was made on the 7th or 8th intercostal space, along the posterior axillary line. The internal wide ring of the port is inserted and the sliding ring pushed down. Placing roll-up guises between fissure to save time. Placing vessel loops between fissure to save time. Finally, attach the access port clamp to the sliding ring. 1.2 centimeter port on the 8th intercostal space along the anterior axillary line with 8 centimeter away from each other. A camera is inserted into the middle port. A Maryland bipolar forceps is installed on the right, as is usual practice for a right-handed surgeon. A Cartier grasper is installed on the left. Left lower lobotomy for steps. Step 1. Division of the inferior pulmonary ligament. The placement of rolled-up gauze between the robot wrist and the structure that needs to be retracted facilitates dissection. The surgeon begins to divide the inferior edge of the inferior pulmonary ligament. The inferior pulmonary vein is exposed. Step 2. Isolation and division of the lower lobe pulmonary vein. The bifurcation of the inferior pulmonary vein and superior pulmonary vein should be exposed and identified. The inferior pulmonary vein is encircled with a vessel loop and then divided using a robotic stapler. Step 3. Isolation and division of the lower lobe pulmonary artery. The fissure is dissected to identify the anatomy of the pulmonary artery. The left lower pulmonary artery divides into the superior segmental artery and the common basal trunk. They can be divided in one step or two steps. We prefer a two-step division. Step 4. Isolation and division of the lower lobe pulmonary bronchus. The left lower bronchial procedure is the same as the previous step. The superior segmental bronchus and basal segmental bronchus can be divided using a robotic stapler in order. At the end of the procedure, the lung specimens are removed. Using a specimen bag through the utility incision, we analyzed the clinical feasibility of the two-port technique by comparing 3-port for robotic thoracic surgery in propensity score matched groups. 2-port's approach for robotic lobotomy may be safe and feasible. Alternative approach for treating non-small cell lung cancer